You are about to watch the introduction lecture to asthma pharmacotherapy. This is the pre-class assignment to our in-class lecture. We will continue on with our diagnosis and management of asthma during live lecture. By the end of the presentation, the learner should be able to describe the factors that can trigger asthma symptoms in patients, describe the hygiene hypothesis and genetic components as proposed etiologies of asthma, and know the primary pathophysiologic events that lead to airway obstruction in asthma. Asthma affects 22.9 million persons in the U.S. This is approximately 7.7% of the population. The most common cause of chronic disease among children is asthma, affecting 6.7 million children. This equates to approximately 12.8 million missed school days per year. The prevalence rate is greatest between those aged 5 to 17. Asthma is the third leading cause of preventable hospitalization in the U.S. Before we can begin describing the pathophysiology of asthma, we first must take a moment to describe the definition of the disease. This is most commonly described as a chronic inflammatory disorder of the airways. There are many cells and cellular elements that play a role in the disease. This includes mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. This inflammation causes recurrent episodes of symptoms including wheezing, coughing, breathlessness, and chest tightness. This may also cause bronchial hyperresponsiveness, which will be further denoted in this presentation as BHR. Asthma is a complex disorder characterized by variable and recurrent symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. And this is further described in the schematic on the slide. Inflammation results in airway obstruction and airway hyperresponsiveness. Both either airway obstruction and hyperresponsiveness can exacerbate each other, furthermore resulting in clinical symptoms. Airflow limitation is caused by a variety of changes in the airway, which all are influenced by inflammation. The three most common factors in airflow limitation include hyperresponsiveness, bronchoconstriction, as well as edema. Remodeling of airways may also occur, and reversibility of airflow limitation may be incomplete in some cases. The etiology of asthma is not well defined. However, it appears that there's an interplay between host factors. Genetics is estimated to represent about 80 to 90% of susceptibility towards asthma. There's actually strong support for the concept of a genetic predisposition. Also, environmental exposure occurs at a crucial time in the development of the immune system, and we'll discuss a little bit further on in the presentation which types of environmental exposures are either protective or risk factors for the development of asthma. The hygiene hypothesis is suspected and supported by studies demonstrating a lower risk for asthma in children who are exposed to high levels of bacteria or endotoxin. There are factors affecting the balance of Th1 and Th2 type cytokines in the development of asthma. There is a proposed downregulation of Th1, which is responsible for infection fighting, and a subsequent upregulation of Th2, resulting in allergic diseases as well as asthma. There are many factors early on in life that can affect the development of asthma, including certain infections such as viral infections, exposure to other children who are in environments such as country living, and those who have exposure to less frequent antibiotics. In the next slide, we'll discuss which of these may in fact be protective versus risk factors to the eventual development of asthma. This slide depicts several risk factors, as well as protective factors in the development of asthma. Risk factors include low birth weight, male gender, exposure to parental smoking, as well as atopy. Some protective factors include those who are exposed to high levels of bacteria and endotoxins, children with a large number of older siblings, early child care enrollment, as well as children who have an exposure to cats and dogs early in life, and lastly, those who have fewer antibiotic exposure. Environmental exposures are the most important precipitants of severe asthma exacerbations. This chart lists agents and events that may trigger asthma symptoms or lead to the development of the disease. As mentioned previously, the respiratory viruses may contribute to the development of asthma as well as influence asthmatic symptoms. Furthermore, there are several allergens, environmental factors, and emotions that may precipitate asthma symptoms or lead to its development. Of note, there are some drugs and preservatives that may also play a role in the symptoms of asthma, as these include aspirin, NSAIDs, sulfites, benzalkonium chloride, and non-selective beta blockers. Lastly, there are several occupational stimuli which may precipitate or trigger asthma symptoms. There are other possible factors which include air pollution, sinusitis, as well as food preservatives that may play a role in the development of asthma symptoms. Now that we've discussed several factors that may either lead to the development of asthma or trigger asthma symptoms, we can now move on to the pathophysiology of the disease. There is a variable degree of airflow limitation within the pathophysiology of asthma. Some of the major characteristics include airflow obstruction, which is related to bronchospasm, edema, and mucus hypersecretion. Along with this, we see bronchial hyperresponsiveness as well as airways inflammation. Asthma is comprised of both acute and chronic inflammation, which we'll go on to discuss in a couple of slides. Within acute inflammation, there's early stage reactions as well as late stage reactions, which may occur in some cases. First, we'll discuss acute inflammation. There are several factors that initiate, intensify, and modulate the inflammatory response. Inhaled allergen challenge models contribute to most of our understanding of acute inflammation in asthma. This leads to an early phase reaction and in some cases is followed by a late phase reaction. First, we're going to spend some time discussing early phase reactions. In an early phase reaction, there's an activation of cells with IgE. This then leads to a rapid activation of both mast cells and macrophages, furthermore releasing histamine, eicosanoids, and reactive oxygen species. This release of these agents results in the contraction of airway smooth muscles, mucus secretion, and vasodilation, furthermore causing inflammatory mediators such as microvascular leakage, exudation, plasma as well. This ultimately results in airway obstruction. However, there are a couple other events that do occur in this early phase reaction. This includes acute plasma protein leakage, which results in thickened and engorged as well as edematous airway walls, and also narrowing of the airway lumen. Lastly, plasma exudation can compromise the epithelial integrity, decrease mucus clearance, as well as exudative plugs. A late phase reaction typically occurs 6 to 9 hours post-allergen provocation. This involves the recruitment and activation of several cells and inflammatory mediators, including eosinophils, CD4 T cells, basophils, neutrophils, as well as macrophages. Plasma proteins also promote the formation of exudative plugs mixed with mucus, inflammatory, and epithelial cells. All of these factors contribute to airway obstruction. Airway inflammation has been demonstrated in all forms of asthma. Both central and peripheral airways are thought to be inflamed. We'll now discuss chronic inflammation in the disease of asthma. As mentioned previously, chronic inflammation is thought to occur in both the central and peripheral airway. There are several cells in the airway that are involved and activated. These include eosinophils, T cells, mast cells, macrophages, epithelial cells, fibroblasts, and bronchial smooth muscle cells. These all regulate airway inflammation. This initiates a process of remodeling by releasing cytokines as well as growth factors. Now that we've discussed the chronic inflammation of asthma, it's important to understand the clinical consequences of this inflammation. There is a nonspecific bronchial hyperresponsiveness that is involved in increasing the risk of asthma exacerbations. This furthermore results in increased symptoms as well as worsening airway obstruction. This tends to occur over a period of days and weeks and very rarely occurs over several hours. The degree of bronchial hyperresponsiveness within asthma correlates with the clinical course as well as medication requirement to control symptoms. Therefore, mild symptoms or patients who are in remission tend to have lower levels of BHR. Airway remodeling can also occur with chronic inflammation, and this causes extracellular matrix fibrosis and an increase in smooth muscle and mucus gland mass, as well as angiogenesis. This concludes our presentation to the introduction of asthma. You will be responsible for this material when we have our live lecture, and we will continue on with the diagnosis and management of asthma in class. Thank you for listening.